Welcome to Fill Up Your Toolbox Chiropractic Technique Seminars. I'm Dr. Paul Hunter, chiropractor. This technique is relating to trunk wraparound pain. You'll come across a patient who has either unilateral or bilateral wraparound trunk pain. What first comes to mind? Maybe they have a rib that's restricted, needs an adjustment. In some cases, they may not have a rib at all, but may have a rotational problem with their lower thoracic between T10 above the floating ribs and T11 and 12. Now, to test for this, you would sit the patient on the table and see if there's asymmetric rotation of the trunk. If there's rotation with wraparound pain that's much more to one side than the other, then you can come to the conclusion that there's probably a twisted vertebrae between T10 and T12. You have them seated on the table and then see if one side turns much better than the other. You'll see a difference from anywhere from 45 degrees on one side to 10 to 20 degrees on the other side. This often comes from patients sitting at a desk repetitively turning to one side. It can come from the living room with the couch facing forward but the TV off to one side. The rotational problem, the fact that the lower thoracic vertebrae is rotated, it may not adjust using a P to A or an anterior type approach. You must use an approach that takes into account the rotation, and that would be with a side posture adjustment. Yes, you can do T10, 11, or 12 using a side posture adjustment, taking into account the rotation. This is an interesting area that can give you a very precise listing, the three-dimensional orientation of the vertebrae. So, in other words, if the patient can turn all the way one way, but noticeably restricted the other way, we would come to the conclusion that the vertebrae is twisted, and the vertebrae will be twisted to the opposite side that the good rotation is. So if they can turn all the way right, this is the back, then not very well to the left, you can assume that the vertebrae is rotated to the left. It can't turn right and accommodate rotation to the left. Secondly, we would look for wedging, and again, light touch palpation. This hand is passive, and we're looking at lateral flexion, looking for binding, going one way or the other. The vertebrae that's rotated, which side is it binding? Which side is the wedge? Well, if they can turn all the way to the right, we've got a posterior left rotation. If the wedging is on the left, we have posterior left rotation to the superior side. Gonstead listing would be PLS. That would mean we're doing a spinous contact because the vertebrae is up to the left and we've got wedging always on the high side of the rainbow, and we're going to adjust that P to A and I to S, left to right. Second listing would be that the vertebrae can rotate one way, but it's to the opposite side of wedging. So if the vertebrae can rotate to the left, meaning the trunk can rotate to the right, yet the wedging is on the right, that would dictate that we've got a posterior left rotation to the inferior side of wedging. That dictates that we would always adjust on the high side of the rainbow. This means we would do a transverse contact, taking out the rotation from left to right and taking into account the wedging on the right side. Again, side posture adjustment. If it's a lot of rotation, you won't get it with a P to A or a anterior adjustment. So using a side posture adjustment, that's how we correct for lower thoracic trunk rotation, which will often make for trunk wraparound pain. Let's see how Laura's can turn. She goes in excess of 45 degrees that way, and then to the other side, she's quite restricted. She's got less than 15 degrees rotation. What we need to do next is look for wedging to develop a specific listing. So we're using the palpation finger. This finger is passive, and we're feeling the inner space which broadcasts the movement of the entire motor unit. We're looking for wedging. Starting at T12, we'll do lateral flexion and feel whether there is symmetric lateral flexion. We're looking for the bodies to move one way and then the other. If we have wedging, one side will bind and the other side will have movement. So we're moving up to T11, and it's good. We got to T10, and clearly there's binding going to the left, so not moving in lateral flexion. Because the patient can turn their shoulders to the right, the rotation of the segment is to the left with right trunk rotation, and it's to the superior side of the lateral wedging. Thus, we have a PLS. That means the spinous contact, the high side of the rainbow, and we're going to use a side posture adjustment to take into account the rotation of that segment. Palpation finger, and we're going to wiggle the spine to get to the segment with the wedging. So just like sitting up, we're going to use this as a passive palpation tool. Remember, T12 is like a long blade-like spinous process. Use your legs to move the patient's knee to wiggle the spine interspaces. Often it's good to go above where the involved segment is. We're just like Sesame Street. It's which one of these doesn't belong here. 9 and 10, and we see that there's hypomobility in this position. We're going to use a fleshy piezoform contact, which is here, to contact that T10 segment. I'm going to get on that, and even though we're up at T10, we're going to do side posture adjustment. We're going to be going P to A and I to S, and taking out rotation left to right. And like that. We're going to see the right is 45 degrees plus, and then the left is now approaching 45 degrees. So we were successful in correcting the lower thoracic rotation problem. Going forward on subsequent visits, continue to check the patient's trunk rotation. When the trunk rotation is no longer restricted and the rotation is full and symmetric, the side posture adjustment will no longer be required. The segment may still require a P to A or anterior adjustment.